Okay, I want to talk about GTN. GTN, particularly its role in emergencies. I'll just write glycerol nitrate because that's what it is. And I'm going to look particularly at its use in ACS, acute coronary syndromes, not older contrast state, acute coronary syndromes. So what is GTN? What is GTN? Well, it's predominantly a vasodilator. I'll put a little star there because it does a few other things as well, which we'll talk about later. But I mean, if you want a little bit more of a technical sort of a name for what it is, it's an exogenous nitric oxide donor. So exogenous meaning the opposite of endogenous, so it comes from outside the body. I mean, we're giving it usually in a tablet. So exogenous, and it's a nitric oxide donor. So we're using the nitric oxide to exert its effects, and we'll talk about its effects later. We say vasodilator, so that's sort of vaso meaning vessels, but primarily it's going to affect our veins more than our arteries. And some say this is a sort of a 3-to-1 ratio. Others say a 4-to-1 ratio. So sort of 3/4 of the effect is seen in arteries, and the dilation effect in 3/4 of the dilation effect is seen in veins, and sort of 1 part of that is seen in arteries. So 1/4 or 1/5 of the effort is seen in arteries. So how's the different ways we can give GTN? So we can give it IV, we can give it sublingually. Well, I'm going to write buccal here as well, because if for some reason you can't stick it under their tongue where it's very vascular, you can put it in the buccal cavity where it's also very vascular. So we'll start there. And the other one I want to do is transdermal. So we're talking here about patches. A patch. Okay. So we can give it IV, it'll be an infusion. So let's write infusion here. And the infusion rates for IV for GTN, say if we're in ACS or a coronary syndrome of some sort, can be a little bit confusing because the PVC tubing of the infusion set can absorb some of the GTN. But we're aiming for between sort of 20 micrograms a minute up, I'll write up to, because we're going to titrate it up to, if we need to, 200 micrograms a minute. Now this isn't as common in emergencies. This is quite common in the emergency ward. So once you get into hospital, they might do an IV infusion or transfer a patient from one hospital to another on an IV infusion of GTN. So you will still see it in say an ambulance setting, but our most common in emergencies, at least in the initial stages, is done with a sublingual tablet or a metered dose spray. So what is the dosage that we're going to give this patient in sublingual? We're going to give them sort of between 300 micrograms up to 600 micrograms. So usually a protocol will say if they've had GTN before, they've got it prescribed to them, we can give them 600 micrograms. If it's their first time, we might try them out with 300 micrograms first. Now, the metered dose spray is something that's prescribed to the patient a lot of the time, or some ambulance services carry it. And I think that's about 400 micrograms a spray. So they don't get much of a choice there. You're just going to give them the spray, or you're not going to give them the spray. Transdermal patches are not generally used in emergencies. They're a little bit more slow release, or they are a lot more slow release. There's usually, they call them 5 milligram patches, or they'll put 2 on them. That's 10 milligram patch. That's 10 milligrams released over 24 hours, or 5 milligrams released over a 24-hour period. So it works out to be sort of 0.2 to 0.4 would be that's micrograms per hour. So that's sort of our patch release, if you like. Normally these will be taken off at night, so the patch might say 24 hours, but the patient will usually take it off at night and then get it put back in the morning. This is due to the body's ability to build up a tolerance quite well to GTN. So I want to have a look at GTN's mechanism of action. So that's right, mechanism of action. There's a bunch of numbers down here. We'll stop there. Okay. So let's say we give it sublingually. This is our absorption. We're talking about our pharmacokinetic principles. That's our absorption sublingually into the blood. We write bloodstream here. And this is our distribution. Our pharmacokinetic principles. Now 3, I'm going to write as vascular smooth muscle. So I'm going to go over to my diagram in a second. Vascular smooth muscle. Basically, this GTN is taken up by the tunica media, which is a little bit hard to see because I've got a white arrow there. Change that to a different color or something. Tunica media, where we can see in a second it's going to have a big effect. So the biotransformation of nitric oxide happens in here. So I'm going to put it as a denitration of the GTN into nitric oxide. That's quite widely disputed as to what takes part in this denitration, what enzyme is responsible, or what organelle, if you like, is responsible, because some say it's the mitochondrial organelle, that takes part in this denitration of GTN into nitric oxide. But nitric oxide is our active metabolite, so it's also known as, we'll put it down here as nitrogen monoxide. So known as nitrogen monoxide. It's actually a highly reactive gas. So this is the bit of like some people might say, oh, I've been prescribed TNT or TNT spray for my heart, and this is because nitrogen monoxide or nitrogen oxide is is used in dynamite basically, and that's actually how they found GTN, by people handling nitrogen oxide or nitric oxide, and then ending up with a big headache, and then they investigated it and worked out what it does. So we'll put 5 as converting G, GTP into sort of like that, into CGMP. So I'll just move down a little bit. So this is guanosine triphosphate, so guanosine 3-phosphate, and then we sort of the nitric oxide, right, here, nitric oxide helps to convert it, or it's actually dephosphorylation to CGMP. And CGMP is cyclic guanosine monophosphate. The guanosine monophosphate, we're losing a couple of phosphates. So phosphates up here. And then we've got cyclic guanosine monophosphate. So let me just let's go 6, 7 here. Keep going. So we get this increase in cyclic guanosine monophosphate. And it's this increase in cyclic guanosine monophosphate that actually results in 3 things. So let's see where I'm at here. We'll just go 1, 2, it results in a inhibition, inhibits calcium ion entry into the cells, entry into cells. This is important because we know that calcium helps cell contraction. So if we inhibit calcium entry into the cell, we're going to get relaxation. With smooth muscle, I'm not going to go too much into how smooth muscle contracts because it is a little bit different to skeletal muscle. And I'll put a link up there that explains smooth muscle contraction a lot better. But basically, calcium goes into the cell. It binds to calmodulin, which activates myosin light chain kinase. This phosphorylates the myosin heads, resulting in increased muscle tension. So we get calcium basically driving the myosin head, which is similar to a sort of similar to skeletal muscles, I suppose. But we don't have the troponin. We don't have the troponin binding system and the tropomyosin. We don't have any of that in our smooth muscle. Okay, the second one is it actually activates potassium channels. So let's say that our inhibiting of calcium entry into our cell is basically the end result is going to be relaxation. We activate our potassium channels. The end result of this is sort of hyperpolarization. So basically we can't sort of make it contract again, even if we, put in a big stimulus to try and get it to contract, it's not really going to contract again. So that's what our dumping a bit of potassium is going to help us with. Now the third one's a little bit more confusing, and I'll write it out. Activate myosin light chain. That's myosin light chain. Phosphatase. Let's get this right. Phosphatase. My spelling's terrible. I think that's right. So the activation myosin chain phosphatase is going to dephosphorylate myosin light chain. So basically, I'm going to simplify it down. We might try and draw. So we've got your actin here. You've got your myosin head. This might require some revision on your part. And then basically what it does is it stops the kick from the myosin head, which results in the contraction. So it basically relaxes the myosin head, which can end up. So we get, let's go relaxing of the myosin head, which we end up in relaxation. That's very clear. Relaxation. And then, so we'll just say the end result of this is smooth muscle relaxation. That's the same as sort of this system of myosin light chains is similar to skeletal muscle system. We just don't have the troponin bonding system. So relaxation. So I mean, it's regulated by calcium anyway. So these two things sort of work together, number one and number three. Okay. That's about it for its action. Let me just go through its last couple of points here. We'll go through its excretion and whatnot, so its metabolism. And then it's metabolized once it's used mainly by the liver. That's right, by the liver predominantly or mostly by the liver. And it's metabolized into various other little metabolites. So we get things like nitrogen dioxide. We're going to get some of that. It's a little bit, there's a couple of things that are a little bit disputed as to what we're going to get, but we're going to get nitrate and nitrite. And then we're going to get rid of these by excreted in the kidneys. Okay, so that's basically our mechanism of action. I've made it a little bit too big here, but we can see, I'm just going to go and highlight sort of the important points if you like. Absorption, that's pretty straightforward. We get in the bloodstream, that's our distribution. So we go from our bloodstream into vascular smooth muscle, that's quite important. Denitration of GTN into nitric oxide happens, so that's really quite important. And then I think you could probably skip this step and still be fairly competent. We get an increase in CGMP, that's quite important. And then that, I think if you're going to remember anything, it inhibits calcium entry to the cells. That's probably the most important factor to remember out of all of this, which results in our relaxation, hyperpolarization, relaxation. It's metabolized by the liver into smaller metabolites and then excreted by the kidneys. I mean, that's you have to learn that sort of stuff anyway, so we'll underline that. So why are we giving this? Why GTN? Just pick a color here. Okay, why GTN? Well, our number one for why GTN is venodilation. So what does that mean? Well, we talked about up there just a little bit about how veins, it definitely dilates veins over arteries, right? And this is like a 4-to-1 or a 3-to-1 principle, something along those lines. As in, veins get dilated a lot more than arteries. But basically, this is going to lead to, I'll draw sort of an arrow, try and make this a little bit schematic if you like. Reduction of venous return. Now, what's a reduction in venous return? Well, that is basically, it is very basic, sort of dumbed down a little bit. It's basically a preload. We're going to reduce our preload. This is going to cause a reduction of our ventricular volume. That's really our end diastolic volume, isn't it? It's sort of the amount that gets filled up. If we draw a little sort of a ventricle here, we're relaxed, and our preload sort of helps push the blood in. So we're getting less sort of less feel, if you like. So that's a reduction in ventricular volume. Reduction of ventricular stress. This is important because this is all very important factors when we're talking about stroke volume. So when we talk about stroke volume, it depends on preload, tick. It depends on afterload, which we're going to talk about in a second. And it depends on contractility, which is part of our ventricular wall strength. So all of these things work to decrease myocardial O2 demand. And that's definitely what we want to achieve. That's our number one sort of thing. I mean, we don't want it to inhibit our stroke volume too much, but that's sort of a way that we're going to encourage decrease our myocardial oxygen demand. Let's talk about number two. I think I'll go different color here. 2 is going to be systemic arterial dilation. Now, I wrote systemic to differentiate it between coronary arterial dilation. And I'll talk about why I sort of differentiated that once we get to point number 3. So this is going to work to actually reduce afterload. Now, reducing our afterload is actually a measure of wall tension of the left ventricle during systole. So This can actually enhance our cardiac output while at the same time reducing ventricular wall strength and oxygen demand. So this is going to basically equal a reduction in BP, blood pressure, okay, which is going to reduction in blood pressure results in lower O2 demand. So it doesn't have to push against a high afterload. So you sort of get the ventricle. So trying to make it red. You get the ventricle sort of filling up, and the ventricle squeezes in. It has to push out against the afterload, which is in our systemic arteries here. It doesn't have to push out. The valve will open a lot easier. It doesn't have to push out against anything that's too hard. So that's sort of that's how our systemic arterial dilation is going to help our myocardial oxygen demand. Let's go to point number 3. Point number 3 is sort of more of a nice to have rather than a great effective. Oh well, it is quite important, but I'm going to write it as mild because it's really mild coronary dilation. I'm talking about the arteries here. So this is actually really important if our ACS or our anginal pain is because of vasospasm. If it's because of vasospasm, then our GTN is probably going to fix this patient for the interim anyway. So that'll be great help. But most ACS is usually because of plaque buildup, and whether it be a thrombus or something. So atherosclerosis is turning into a thrombus. So I don't think that this is going to really fix your patient, but the can enhance oxygen supply and demand ratio and diminish the anginal pain. So we talk about collateral arteries. So we have like a left artery going down here. We have like our right coronary artery going down here. They might have a little bit of a network that sort of joins them together. And if we can dilate, this section here, we might be able to get, say our right coronary artery is still good. We're still getting blood flow through here. We might be able to get a little bit of dilation that will help pull up our blood flow here because our blood flow is stopped here. So we talk about that as being one of the advantages of GTN. Whether it's works that effectively is up for debate. But so that's sort of one of our, let's say, how can I word that? So well, it can work to increase blood supply. Now, I just wanted to finish with a couple of sort of important or more interesting points of GTN. So we've got lots of contraindications. I think I might make another video on all of the contraindications and why they're there and why we can't give it. It's really sort of going to be detrimental to the patient. We can almost kill patients with GTN if we don't give it at the right time, or if we do give it at the wrong time. Withholding's generally not going to kill them, you think, but if we give it in patients that have like a right ventricular failure, for example, we can really do lots of damage to this patient. So, but I'll talk about that in another video, I think. I'll write this one down, but nitric oxide has actually been found to be a neurotransmitter in some neural pathways, so that's a little bit interesting. Nitric oxide not only helping in our vessel network, it's also helping our neurotransmitters as a neurotransmitter, and that's in the autonomic nervous system. So with noradrenaline and acetylcholine is the other one. So it can actually, I'm going to write this one down actually, inhibits this is minimal, but it does work to inhibit platelet aggregation. So, in ACS, we normally in a protocol it'll say, number one, give an aspirin. Aspirin's going to help with our inhibiting of our platelet aggregation. And number two might be give some GTN if they're not contraindicated. Well, this is GTN is actually going to help with our platelet aggregation as well, and it helps prevent sort of platelet aggregation, and it helps prevent neutrophil aggregation as well. It's got a really short half-life, so I think I'll write that down. Half-life. That's a half-life. Something like 3 minutes. What else is the tolerance, which I already touched on. So tolerance. That's why some guidelines say, if the patient's had GTN before, just go straight for a 600 microgram dose, because they will have built up some tolerance, increase the tolerance. So the 300 microgram dose is really not going to do a whole lot. And that's basically all I wanted to talk about as far as GTN. So if you have any questions, let me know. I'm going to put up a couple of interesting links in the description for the video. It's particularly if you want to learn about vascular smooth muscle contraction, which is the principles behind vascular smooth muscle contraction and how they differentiate from skeletal muscle